My screen is frozen.
Oh, we can hear you, Molly. I mean, Margie, sorry, confuse your names now. We can definitely hear you.
Hi, everybody. Welcome. I'm so happy to see you all. My name is Margie Beaudry. On behalf of Trust for America's Health, I'm pleased to welcome you to today's Huddle call to discuss challenges and solutions for ensuring access to the COVID-19 vaccines for older adults and people with disabilities who cannot leave their homes. Please mute your lines unless you are speaking. This session is being recorded so that we can capture all of the ideas and experiences shared. This call series is part of an initiative to identify.
Cool.
This call series is part of an initiative to identify and foster adoption of innovative and promising practices on this topic. This work is made possible through the generous support of the John A. Hartford Foundation and the Cambia Health Foundation, both of which are dedicated to improving health for all. When TIFA began this initiative in February, next slide, please. When TIFA began this initiative in February, very little was known about the challenges of ensuring that older adults and people with disabilities have access to the COVID-19 vaccines. And since that time, CDC has produced guidance, additional funding has become available through the Administration for Community Living, which we heard about last week, and there has been much media attention focused on this issue. Working together with many of you, we've developed a set of policy recommendations that will soon be published and disseminated to help inform and guide policy leaders across the country, as well as some very practical guidance that will be posted on TIFA's website very soon. Despite the increased attention to this issue, next slide, please. There are still a lot of complexities, including the developing situation with the J&J vaccine pause, and many state and local jurisdictions have not yet fully identified their homebound populations, nor have they been able to implement systemic strategies for vaccine distribution to those at home. Our speaker today, our speaker today is Molly Gurian from the LeadingAge. And she will be sharing some valuable information about the work of LeadingAge on policy related to those who are homebound. And I'm at this point, we'll take the slides down and welcome Molly to say hello.
Hi, everybody, and I'm excited to be here today. Thank you for the introduction. My name is Molly Gurian, and I'm the Director of Hospice, Palliative, and Home Health Policy for LeadingAge. LeadingAge is a national association of over 5,000 mission-driven aging services providers. So that includes nursing homes, assisted living, continuing care retirement communities, independent senior living, including HUD assisted senior affordable housing, home health, hospice, PACE organizations, and adult day providers, and probably a few that I'm forgetting. And we also recently completed our affiliation with the Visiting Nurse Associations of America earlier this year. So we are the aging services continuum, and that continuum perspective informs our policy positions and our worldview. It'll also inform this discussion today because there are lessons to be learned from efforts to vaccinate the homebound wherever they call home, whether in a home in the community or in a congregate setting. So while some of what you hear today may have been covered in other huddles and certainly in the policy conversations that TIFA has been hosting, I think we're clearly at a turning point. There's enough vaccine, and we're starting to read about states turning down vaccine because they're not using it. In many places, you no longer need an appointment to get a vaccine. So we're passing the point of scarcity as a constraining factor. And I'm looking today to sort of summarize what we've seen so far to set the stage for a discussion about where we go from here. The number of seniors vaccinated is being reported at about 80%. I don't know that we have those numbers for the disability community, but getting to the homebound is likely a big part of that last 20%. And I think from LeadingAge's continuum perspective, I've been exposed to a number of approaches and a number of challenges. So how can we use those lessons to get to that last 20%? And how do we have to think about this population differently now that we are in a slightly different environment than we were when this process started? So our members' vaccination journey probably started out differently than some of the others who have talked on this call previously. Given the high risk nature and mortality of congregate care settings, as many of you may know, the CDC had a federal pharmacy partnership. And I'm going to describe a little bit about what happened with the partnership because I think it stands in contrast to our efforts so far to vaccinate homebound older adults who are similarly clinically situated but have a different living situation. It also underscores some of the logistical challenges our members are facing that are looking to vaccinate homebound older adults. So contrasting these efforts, I think, provides some perspective as to future approaches. And I'm then going to talk about the challenges that our members, I've mostly talked with home health, hospice, and PACE programs, but some others as well, have faced in trying to set up vaccination programs for the homebound. And then I'm going to talk a little bit about some solutions based on all of the lessons learned. And then we can hopefully have a conversation or I can take questions. So the pharmacy partnership, federal pharmacy partnership, partnered Walgreens and CVS with nursing homes and assisted living facilities that registered. States had discretion regarding the inclusion of other settings like HUD 202 housing properties and independent senior living that were, for example, on the same campus as an assisted living facility or a nursing home. So each site got 3 clinics from their pharmacy partner. So some challenges at a high level included staffing the clinics. Were there enough people who could give the shots? Who was responsible for filling out the paperwork? The pharmacy partnership was responsible for submission, but some of our members actually helped with filling out in order to expedite. Coordination with the CVS or Walgreens on dates and times for the clinics. How do you reach the hesitant? Many people were hesitant and did not get vaccinated at the first clinic, especially amongst the staff. And as the second and third clinics rolled around, the numbers of willing participation increased, but it really shows the need for education, which is something we're going to see reflected on the homebound side as well. And then state variation. States had different policies about what sites could participate, how much control they exerted over the program, and other factors like that. Despite these challenges, obviously setting up a coordinated program was a boon to reaching older adults and those who serve them. While targeting the homebound who live in a congregate care setting is easier than for those who do not, I think it's really a public policy failure that a similar effort has not been attempted for older adults who reside in the community. And while I don't think at this point we can wholesale start a new program, I think that it's important to think about the lessons learned and how it can apply and what we can do with the money that it sounds like it was talked about last week to make the vaccinating the homebound in the community more straightforward. So LeadingAge has a number of members who are attempting to reach those who are homebound in the community, but have run into the logistical problems that we saw with the pharmacy partnership, plus some extra. So a big one is defining who would have access and who's homebound. In the Medicare home health benefit, there's a very specific definition of homebound. You need the help of another person or medical equipment to leave the house, and it has to be difficult for you to do so. So while leaving the home for a vaccine would fall into one of the scenarios that would not interfere with qualifying criteria, for the purposes of reaching the hard to reach for vaccination, there's no uniform way to assess who might be qualified to receive a vaccine at home. That Medicare home health definition is likely too narrow. There are those who would struggle with mass vaccination, even if they're too mobile to qualify for home health. If a person is not enrolled in home health services, someone would have to assess their homebound status, which creates another barrier to vaccination. Finally, caregivers who may be physically able to get to a pharmacy or mass vaccination site, but struggle to have the time to do so due to their caregiving responsibilities is something that we really have to consider. Especially given the increasing supply of vaccine, it makes sense to try to place as few barriers as possible on receiving vaccine at home and to try to get as many household members as possible. So getting vaccine, unlike the pharmacy partnership that ensured doses were set aside, providers trying to reach the homebound have had to figure out a partnership to get vaccine. So they've worked with their local health departments, some have worked with EMTs, some have worked with hospitals. Now that there's increased supply, hopefully this process is getting increasingly easier. But you still have to handle the vaccine itself. We have members that have brought special refrigeration equipment for their offices. We have others that even have their own pharmacy that the state was able to distribute the vaccine to. However, even if the agency finds a way to store the vaccine, transporting it is another question. We have heard that EMTs or firefighters are getting more access to resources, potentially like refrigeration trucks in some localities. Partnerships to increase who can have access to these types of resources is something we're hearing from our members would help, since it could delay when the vial has to be opened. As I'm sure has been highlighted on these calls in the past, once a vial of vaccine is opened, it has to be used within a short time frame. We have a member, for example, who has their own pharmacy who's been receiving the vaccine supply from the state directly, but there were still administrative staff, including the chief operating officer, driving from the centralized storage location to meet nurses with vaccine to cut down on the travel time for the nurse, so that as they're trying to make those homebound visits, they aren't cutting into the 6-hour time frame that they have to meet in order to use up all the vaccine in a vial. As was mentioned at the top of the call, the pause on the Johnson & Johnson vaccine is also throwing a wrench into some of these efforts, since a one and done approach was much easier. Johnson & Johnson also had fewer doses per vial, so there was not as much pressure on grouping as many appointments per day. So hopefully the deliberations over its utilization can be concluded rapidly and it can be safely returned to the field. Another logistical issue that I haven't heard as much about is the waiting period post-vaccine, which increases challenges of moving between appointments, as well as ensuring a supply of anaphylactics. If you come to get your vaccination at a mass vac site, the site has EpiPens, not enough for every person coming through, but a good supply. So going from home to home, a provider would have to bring EpiPens for all the appointments. EpiPens are expensive, and I haven't heard of a situation in which they're being covered as part of this effort. So my providers are paying for them themselves. So some states and localities have invested in how to vaccinate the homebound with an overarching phone number that can be called. This is often in conjunction with a local health department. And then there are some who have individual providers who are helping to schedule the appointments. So we have some members who run their own health plans, and they're using their health plan resources to help schedule the appointments, though those tend to be limited to plan members. So there are a number of approaches. The challenge is that it's very localized and incredibly varied. If I receive a call from a member in Ohio who got a call locally about a patient needing a vaccine at home, there's not any uniform answer I can give them about how to access a vaccine or help that older adult. State licensure has also been a big barrier. Getting licensed to actually give vaccine is something that needs to be done in some states. There are also scope of practice barriers. So we had a member who was a hospice, and they could not get confirmation from the state that the hospice medical director's oversight extended to home vaccination. So this barrier overlaps with benefit enrollment as well. So with hospice patients, for example, our members wanted to focus on getting the family caregivers vaccinated as their first round, but those caregivers aren't enrolled in the benefit, and it wasn't necessarily clear whether they were able to do that. Similarly, in home health, agencies theoretically would want to include family members while they're out at the home, but it's not clear whether it's within their scope of practice, and that varies from state to state. So finally, hesitancy. In the pharmacy partnership, there were multiple clinics which allowed it second and third chances to access vaccine. If there was a central scheduling location, people could call when they were ready to be vaccinated, but we still need to think about the education process. We want to make sure that when a provider arrives at the home to vaccinate, that hesitancy doesn't lead to a spoiled dose. You also likely have a family unit to convince with a homebound patient. We've heard of family members who don't want to get their loved ones vaccinated. So the agencies are really working through with the family and have the experience to work through with the family to get to the point of yes, but we have to make sure that those resources are available as well. So just to conclude, creating a federal program like the Pharmacy Partnership for Homebound Adults outside congregate care is probably not a feasible solution at this point. There's too much state and local activity going on, but there was a lot of money directed at vaccination in the rescue plan. So we're hopeful that some of this money can go towards supporting logistics like appointments, directing vaccine doses, and finding providers who can be vaccinators, as well as education. Considerations around access and equity dictate that we should be as inclusive and possible as this program with these programs. So it'd be helpful to set up fairly generous criteria. However, I think at this point in the process, we should be thinking about who might be able to access a vaccine, who are technically homebound, but where else are they maybe going that they could maybe get vaccine? For example, homebound adults do attend adult day programs. So adult day programs are places where those older adults who, for the most part, are homebound may be going on a regular basis. So that would be a place to access them that would provide sort of that community setting where it'd be easier to administer the vaccinations, but you're still getting to those hard to reach individuals. Similarly, I think at this point, we should be having a conversation about making sure that doctors' offices get access to vaccine. If a homebound older adult is going to leave their home, they're probably going to do it to see their doctor if they leave at all. And they also have more trust in their doctors. There's also discussion around transportation to vaccine. What about respite care for caregivers so that they can go get a vaccine? How can we start to facilitate that? So these are just some ideas that we've been talking about at LeadingAge and that we've been seeing, as well as how to continue to link our members to some of the new resources that are coming online after the American Rescue Plan. So I'm looking forward to any questions and to discussion.
Wow. Well, Molly, thank you. I think yours was probably in some ways the most comprehensive coverage of all of the issues that have come up in the course of our discussions over these last few months. Obviously, you know a lot about all of these things, but you're coming from a perspective that is somewhat fresh. So you definitely mentioned some things that I don't think had come up in conversations earlier. So I thank you for that. Yes, we invite everybody on the call to raise your hand in the chat or pop a note. Raise your hand or pop a note into the chat so that we know that you want to join the discussion. We do have some questions on the screen to help kick us off. And I'll open it up for discussion. Go ahead, Megan.
Now, I was going to just looking at the last question on this list, Molly, in terms of what you've learned, what you all have learned through your members and the lessons that you think are important to carry over to implement and adopt as practices or partnerships that have been established as a result of the emergency that you think will be important moving forward, just for the general welfare of older adults, but also for future emergencies.
Yeah, so I think that LeadingAge has worked with CDC in a way that we never have before. It's not an agency that we usually have a lot of interaction with. And I think that we've learned a lot from them and they've learned a lot from us about reaching older adults, about both congregate and non-congregate care settings where older adults get services, what kinds of services. So I think that continuing to further that federal partnership for the future is incredibly important and incredibly valuable. And I think the other is on the local level with local health departments. I think that access has really varied depending on our providers' relationships with their local health departments. The ones that had or developed great relationships have been more successful. LeadingAge has been holding regular coronavirus calls. And just last week, we had one with the King County Health Department. And, they've had, I'm sure you've had them on these calls before, but like their focus on the aging services and the integration between aging services and the health department has made them particularly successful in reaching the hard to reach and seeing that duplicated around the country. But I think that having some federal floor has been helpful. I think as much struggle as there was with the CDC pharmacy partnership, and even though there was still state variation, having some help from some standards and some help from the federal government about who was supposed to be covered and who was doing the vaccinations. We knew that it was CVS and Walgreens, even though it was there were challenges. I think that's something that could be built on and made to work even more smoothly.
We have talked a great deal about caregivers in these discussions, and you brought up a point that I don't know had really come up before, which was the need to provide respite care so that the caregivers can in fact get vaccinated, because as you pointed out, it's not always possible for them to be part of the homebound vaccination. That isn't always permitted. We know that in some localities it's happening anyway, but it isn't always something that's allowed. So I'm curious, what kinds of ideas are emerging around providing that kind of support?
Respite care is something I've been working on throughout this pandemic, especially from the hospice perspective, because it's just something we've heard was needed as a result of this pandemic, because people were just respite in hospice is provided in an inpatient facility, and there was just a huge hesitancy to do that. So we tried to do some advocacy to allow for home respite. And even outside of hospice, there have been some studies that have started to come out that have shown that respite was one of the most asked for benefits during services during the pandemic. There was a study from NORC that came out that cited that. So I think that as I was thinking about doing this presentation, I was thinking about what are ways that if there are scope of practice barriers, how do you flip that on its head? And to me, you bring somebody in to help the caregiver, and they probably need it for other reasons besides getting a vaccine. So maybe you're hooking them up with a new service that they can use in the future. I haven't heard of anybody doing this yet, but I think that it's something that could really be explored. And given the partners that are on this call, who I know are all invested in the health of family caregivers and are promoting more robust respite care across the continuum, it's an interesting way to start to get that to happen.
There's a comment in the chat from Karen Marshall. Karen, do you want to jump on and just share your thoughts?
Sure, thank you. Hello, everyone, and thanks for this very comprehensive list of questions.
Karen, I can't hear you. I don't know if that's my computer or if it's others.
Hello, is this any better?
Much
Yes,
better.
it's much better.
Okay, sorry about that. My headset wasn't connected. Apologies. Again, thanks for the presentation, and thanks for holding these weekly meetings and for this comprehensive list of questions. These are a lot of the things that we're hearing from advocates in our network. And I just want to kind of punctuate for everyone on the call that a lot of the pandemic has just really amplified a lot of the concerns that family caregivers had even before the pandemic. And I think and the advocates in our network think it's very important to kind of look at the current situation for opportunities to implement best practices for the future and for future emergencies. And one of the conversations we were having before the pandemic was just pathways for caregivers into receiving services and supports. And I just want to punctuate that for everyone. Caregivers access most services via the people that they're taking care of, but I think that now is an opportunity going forward for us to think about ways that we can proactively create those pathways so that this network of support is able to be activated the next time that there's an emergency.
Yeah.
Thanks for listening to that.
Thank you, Karen. Absolutely, and I think you're probably expressing the sentiments of lots of folks. Jody, Moss has in the chat brought up a topic that I'd love to get into a little bit more related to the paid caregivers in the home. Jody, do you want to share your thoughts?
Sure. So I work for an area agency on aging, and we are really involved in getting vaccines to homebound right now in the 4 counties we serve in Washington State, and they are very rural counties in places even considered frontier. So what we are calling clients who we would consider homebound, and a few of the clients have mentioned that they're paid caregivers who are home care agency workers or independent home care providers. And they have said if their home care worker does not get the vaccine, then they will not. And it just highlights that level of influence that a home care aide may have. And this is an individual who may have very different knowledge level around the vaccines. So, it's an area that I think we need to do some education and outreach around. And then since I added the other information, we contract with volunteer. And sorry, I've got another meeting coming up that I'm getting reminders for. Anyway, there are some people who might be able to get into a vehicle with some assistance, but just need that transportation. So we are contracting with taxi services. If we have some Uber and Lyft drivers in our communities, we are reaching out to them. And then we are also actually paying for ads for the volunteer transportation providers to recruit more volunteers to drive people to vaccines. We think that that's something where we may get a lot of volunteers who are just willing to do that from a community building perspective.
Jody, that's really great, and and the home health aid point is really important. On the volunteer front, hospices have slews of volunteers. Have volunteers. They have a volunteer requirement, and those volunteers have had to be on the sidelines for most of this year. I mean, they've been doing some virtually, but because of the pandemic, and I bet that partnerships with them to engage their volunteers to do some of that transportation would be welcomed. So that's something I hadn't thought of that I can suggest to my hospice members who are looking to help, who might not have the capacity to set up a home vaccination program because of all the barriers I discussed.
Hi, this is Maggie Ornstein. Just in terms of respite for caregivers, my research looked at kind of this issue around family members not self-identifying. And what I found was that, and this I think goes back to, was it Karen's comment, that family members often try really hard to get services and for a variety of reasons, aren't able to get them in the way that are useful for them. So they ultimately say, I'll quit my job and I'll do this myself. And so with respite, we have to be really careful. Like, I think having a person come, so a new person, a stranger comes so that someone can go get a vaccination is not, what people might use, right? Because, so like thinking about consumer directed and other ways to get neighbors or people to spend some time with a person who they might know rather than having a new service come in at a time like this. And I think also family members might not want people in who are not getting vaccinated, right? So the flip side of the home care worker not being vaccinated, so the person won't get vaccinated. I think there's also families saying we don't want anybody to come in right now during this emergency.
Yeah, I agree. It's not a one size fits all. And for some people, it's not going to work. But there might be people, I was just trying to think of through some solutions where it could be an access to a new service where it fits the person's needs. But right. I think all your points are super valid.
For the family caregiver as opposed to the patient, right? So thinking about how we brought in, and I think this moment is good for that.
Yeah.
So with the hour coming to a close, let's take ourselves to the last slide. I want to thank you so much, Molly, for joining us and for sparking a thoughtful conversation. All the information you shared, really appreciate you coming and spending some time with us. We will be sharing the slides and the recording following this event. TIFA is continuing to host these 30-minute Huddle calls on Wednesdays and Fridays on topics related to enhancing the COVID-19 vaccine for the people who need them administered at home. And our next call is on Wednesday, April the 28th. We hope you will join us and spread the word. I am, as always, pasting the link to the registration in the chat. I want to thank everyone here for continuing to stay with us for these conversations. And I want to thank you for all that you are doing. Have a great weekend.
Thank you.
Thank you, Molly. Really appreciate it.
Thank you.